Welcome to this deep dive RadBio edition. Today we're tackling total body irradiation syndromes.
Yeah, TBI. We'll be unpacking what happens when someone gets a significant whole-body dose of radiation. Relevant in an accident, sure, but also used medically, like prepping for transplants.
Right. Our goal here is to give you a really clear picture of the immediate and acute effects. We'll focus on, the dose levels, the timelines, and which organ systems tend to fail first.
Okay, let's dive right in. So what's the absolute first thing that happens? The body's initial reaction.
That's the prodromal syndrome. It kicks in pretty fast, minutes to hours after the exposure. It's like the body's immediate, whoa, something major just happened response.
And I assume how bad it is and how quickly it starts, that's linked to the dose, right? Like higher dose, faster, worse symptoms.
Exactly. Generally very dose dependent. And these early symptoms, they tend to fall into two main buckets, you could say. First up is gastrointestinal stuff.
Ah, yeah. The usual suspects. Loss of appetite, that's anorexia. Nausea, feeling sick, and vomiting.
Vomiting is actually a really key one early on. When it starts, can give you a rough but pretty useful estimate of the dose received. Super important for triage.
That's interesting. So like a low dose, maybe 1 gray. Not everyone vomits, and it might take a while.
Precisely.
Yeah.
But you crank that dose up to, say, 4 to 6 gray, and almost everyone gets sick, and it could be within just an hour or two. Diarrhea usually comes in at even higher doses.
Okay, and here's a critical point, right? If someone has diarrhea almost immediately.
Yeah, that's a really bad sign. Suggests a very high dose, probably what we'd call super lethal, life-threatening territory.
Got it. What's the other category of prodromal symptoms?
Neuromuscular stuff, things like feeling tired really easily, that easy fatigability, or just apathy or lethargy, lack of energy, lack of interest.
And at those really high, super lethal doses, I guess this gets worse too.
Oh yeah, you can see fever, low blood pressure, hypotension, headache, confusion, problems with coordination, that's ataxia, and even reduced consciousness.
How long does this first phase, the prodromal phase, last? Does that depend on dose too?
It does. For those massive doses causing the cerebrovascular syndrome, it might only be minutes. Really brief.
Wow.
But for doses that are more likely to lead to the hematopoietic syndrome down the line, this prodromal bit might last a couple of days before things quiet down for a bit.
Okay, so after the prodromal reaction, you mentioned things quiet down. That's the latent period.
Exactly. There's this latent period. Could be hours, could be weeks. Again, very dose dependent.
And this is tricky, right? Because the person might actually feel better during this time.
Yeah, it's deceptive. The initial nausea, vomiting, fatigue might fade. They feel like they're maybe over the worst of it.
But underneath, the damage is still progressing silently in those key organ systems. And then comes the manifest illness phase.
Right. That's when the specific symptoms of the different acute radiation syndromes, ARS, really show up. And these syndromes are defined by which main organ system is failing. And that's strongly, strongly tied to the dose.
Okay, so the 3 big ones we need to know are hematopoietic, or bone marrow syndrome, gastrointestinal, or GI syndrome, and cerebrovascular, CV syndrome, sometimes called CNS syndrome.
Those are the main 3. And to really grasp the severity, we need to talk about the LD50-60, lethal dose 50-60.
Right, the dose that would kill 50% of people within 60 days if they got 0 medical help. It's a crucial benchmark.
Definitely. Okay, so let's really drill down into these syndromes, starting with the hematopoietic one, the bone marrow syndrome.
Okay. What's the dose range for that?
We typically think about 2.5 to 7 gray, whole body. But it's important to remember you can actually see changes in blood counts even lower, maybe down to 0.5 gray.
And that LD and TD60 we just mentioned, without medical support, that falls in this range.
Yeah, usually cited around 3.2 to 4 gray. Shows how even a gray or so difference can really impact survival chances without help.
Makes sense. So the main target here is the bone marrow, the hematopoietic stem cells.
Exactly. Those cells are constantly dividing to make all our blood cells, red cells, white cells, platelets. They're the factory.
And the radiation basically just damages or kills off these factory workers, the stem cells.
Pretty much. It hits those rapidly dividing stem and progenitor cells hard. Now, the mature cells already out in the bloodstream, they have a limited lifespan.
Right. So after the radiation hit, you've got that latent period where the existing cells are just aging out, dying off normally. But the factory's busted, so no new ones are coming online to replace them.
That's the core problem. Let's walk through the timeline. You get the prodromal stuff, nausea, vomiting, maybe for a day or two in that 2 to 5 gray range.
Then the latent period. Could be 1 week, could be up to 4 weeks. Patient might feel okay.
Yep. But then manifest illness hits, and you start seeing the blood counts drop. But they don't all drop at once.
Right, because they have different lifespans and sensitivities. Lymphocytes go first, right? They're super sensitive.
The most sensitive. Their numbers just plummet, hours to maybe a day or two. Actually, how fast and how low they drop the lymphocyte depletion kinetics, that can be a really good early biological clue about the dose, a biological dosimeter, essentially.
Okay, lymphocytes first, then what? Neutrophils.
Some neutrophils, yeah, or granulocytes.
Mhm.
You might see a brief initial jump that's called demargination, cells getting flushed off vessel walls, but then they start to fall. They hit their lowest point, the nadir, usually around 3 to 5 weeks out.
And that low neutrophil count, neutropenia, that's what makes people so prone to infection.
Exactly. Huge risk of infection. Then platelets follow a similar path, dropping after the neutrophils, nadir also around 3 to 5 weeks.
Leading to thrombocytopenia and a risk of bleeding.
Right. And finally, red blood cells. They live the longest, so anemia develops more slowly over weeks.
So if someone dies from the hematopoietic syndrome, when does that typically happen and why?
Usually it's between 2 to 8 weeks after exposure, often in that 30 to 60-day window. And the cause? Overwhelming infection because of no neutrophils, or uncontrolled bleeding because of no platelets, or both.
Now, you mentioned this one is the most treatable.
Yeah, of the 3 main syndromes, this is the one where medical intervention can make the biggest difference. Supportive care is absolutely critical. We're talking antibiotics, platelet transfusions, and those hematopoietic growth factors, the GCSF, GM-CSF, to try and kickstart the marrow again.
Like giving the factory a boost signal. What about bone marrow transplant?
That's considered for really high doses, maybe above 7 or 8 gray. But the tricky part is, at those doses, the damage to other organs, especially the gut, starts to become the main problem limiting survival, even if you could fix the marrow.
Right, which leads us nicely into the next one, the gastrointestinal or GI syndrome.
Yep, dose range here. We're talking higher now, generally in the ballpark of 7 to 15 gray, though you can see significant GI issues starting around 6 grays. So there's definite overlap with the severe end of hematopoietic.
And the target is the lining of the gut, especially the small intestine.
Exactly, that epithelial lining. Think about those cells constantly turning over to absorb nutrients and keep bacteria out.
So what's the mechanism here? Radiation takes out the stem cells in the crypts.
The crypts of Lieberkühn, yeah. Those are like the little factories down at the base of the intestinal villi that make the new lining cells. Radiation sterilizes those stem cells.
Okay. But the mature cells already on the villi, the finger-like projections, they're more resistant.
They are more radioresistant, yeah. But they only live for a few days naturally.
Ah, so they slough off like normal, but because the crypt stem cells are knocked out, there are no new cells coming up to replace them. The villi basically get stripped bare.
That's exactly it. The villi shrink, becomes denuded, and you lose that critical mucosal barrier. Huge consequences for fluid loss, nutrient absorption, and, crucially, it lets gut bacteria invade the bloodstream.
Like the security wall is just gone. So timeline for GI syndrome starts the prodromal again.
Yep. Nausea, vomiting, but often severe diarrhea right from the get-go within hours.
Then a latent period. Is it shorter here?
Much shorter, typically. Maybe just 2 to 5 days. Again, that deceptive feeling better phase.
And then the manifest illness hits hard. What does that look like?
Usually around day 5 to 7, you see that severe diarrhea come back, often bloody, massive dehydration, dangerous electrolyte problems, can't absorb anything.
And that breakdown of the barrier lets bacteria cross over, leading to sepsis.
Yeah, bacterial translocation leading to sepsis. It's a major killer in GI syndrome.
So when does death typically occur and from what?
It's much faster than hematopoietic,
Yeah.
usually within 3 to 10 days, maybe up to 2 weeks post-exposure. Cause is usually dehydration, electrolyte chaos messing with the heart, or just overwhelming sepsis.
And treatment sounds tough.
It is very tough. It's primarily supportive, aggressive IV fluids, trying to replace electrolytes, nutritional support, and really heavy-duty antibiotics.
But the prognosis, if you're in the full-blown GI syndrome dose range,
it's generally very poor. The intestinal damage is often just too severe to overcome. And remember, these patients also have profound bone marrow failure happening simultaneously. But the GI issues usually kill them first. Okay, moving on to the third, and most severe, the cerebrovascular syndrome, CV or CNS syndrome.
the doses here are extremely high, right?
Astronomical, really. Greater than 50. Gray, whole body is the classic trigger. But you can start seeing neurological signs and vascular issues even lower, maybe above 20 or 30 gray, overlapping with severe GI.
And the target, brain and its blood vessels.
Central nervous system and the vasculature, yeah. Exactly which cells are the most critical weak point is still debated a bit. Maybe the endothelial cells lining the brain's microvessels, maybe neurons, maybe glial support cells. It's complex.
And the mechanism, the pathophysiology, also complex.
It's very, not fully worked out. But it seems to involve damage to those blood vessels, inflammation, vasculitis, making them leaky. That leakiness leads to fluid buildup in the brain, cerebral edema, brain swelling, plus possible direct neuron damage and a big inflammatory reaction.
And the timeline here is frighteningly fast.
It's extremely fast. Prodromal starts almost instantly, minutes to maybe a few hours. Extreme nausea, vomiting, plus those really worrying neurosigns, anxiety, confusion, ataxia, loss of consciousness, seizures.
Latent period, almost non-existent.
Yeah, very short, minutes to hours, or maybe skipped entirely. It just crashes into the next phase.
Which is the manifest illness phase.
Right, characterized by rapid neurological deterioration, increasing lethargy, profound drowsiness, somnolence, tremors, more seizures, eventually coma, and then cardiovascular collapse.
And death occurs incredibly quickly.
Yeah, usually within 24 to 48 hours, sometimes up to 72. Main causes of that massive pressure buildup inside the skull from the edema and the heart and blood vessels just giving out.
Treatment options.
Sadly, none are effective for CNS syndrome itself. Care is palliative, focused on comfort, and of course at these doses the GI and hematopoietic systems are also completely wiped out. But death from the brain failure happens so fast, those other syndromes don't really get a chance to be the primary cause of death.
It's important to remember these aren't always neat, separate boxes, right? There's overlap.
Absolutely. Like around 6 to 10 grays, you're dealing with severe hematopoietic failure and significant GI damage happening at the same time.
And above 10 grays, you've got the GI syndrome plus total bone marrow ablation.
Exactly. And over 50 gray, well, everything's failing. CNS, GI, hematopoietic.
And you also hear about multiple organ dysfunction syndrome, MODS, especially at those higher doses.
Right, above maybe 6 to 8 gray. It's not just direct damage to those three classic systems. The radiation can trigger this massive systemic inflammation that harms other organs too, lungs, kidneys, liver. It becomes a whole body failure.
Okay, let's try and crystallize some of this. Any good mnemonics or clinical pearls?
Yeah, here's a simple mnemonic for the order and speed based on dose. Think higher the gray, closer to heaven.
Ha! I like it. So H for hematopoietic death in weeks, G for gastrointestinal death in days, C for cerebrovascular death in hours. That works.
Exactly. Now, a clinical pearl. Early vomiting. If someone exposed starts vomiting within hours, especially if lots of people exposed are doing it, that strongly points towards a dose in that hematopoietic to GI range, say 1 to 6 gray or more. Time to emesis is a really practical triage tool.
Good one. Another pearl.
Lymphocyte kinetics. Watching how fast those lymphocyte counts drop in the first 24-48 hours. It's a valuable early indicator, a biological dosimeter of how much radiation they received. Serial CBCs are key.
Makes sense. And one more pearl regarding prognosis.
Just reiterating, hematopoietic syndrome has the best shot with treatment. GI syndrome, prognosis is much worse. Cerebrovascular syndrome is essentially uniformly fatal right now.
Okay, thinking about clinical decision-making, say you're faced with a mass casualty situation, how do you triage?
You use those early clues, prodromal symptoms, especially time to vomiting, any neurosigns, and if you can get them, those early lymphocyte counts. Put it together to estimate the dose range for each person.
And that estimated dose plus the syndrome that develops really dictates the prognosis, right?
Absolutely. Hematopoietic, best chance with support. GI, very guarded. CNS, unfortunately, likely fatal.
So management follows from that. Hematopoietic gets the aggressive supportive care, antibiotics, platelets, growth factors.
Right. While for GI and CNS, the focus shifts more towards palliative care, managing symptoms, providing comfort.
And let's circle back to LD50-60. We said 3.2 to 4 gray without support. How much does good medical care help?
It definitely helps. Good supportive care antibiotics, transfusions can push that LD50-60 up, maybe into the 5 to 7 gray range. But once you get above, say, 7.5 or 8 gray, even with considering a bone marrow transplant for the hematopoietic failure, the damage to other organs, especially the gut, makes survival really challenging. All right, ready for a quick board blitz? Test ourselves.
Let's do it. Hit me.
Question 1. Patient gets 8 gray whole body, nausea, vomiting initially, then feels okay for about 5 days. Then, bam, severe bloody diarrhea, dehydration. And what ARS is this? A, hematopoietic. B, cerebrovascular. C, gastrointestinal. D, cutaneous.
Okay, 8 gray is definitely in the GI range. Prodromal, short latent, then severe diarrhea. Maybe C. Gastrointestinal syndrome.
Correct. Question 2. What's the approximate LD50-60 for unprotected adults after acute TBI? A, 1 to G guy. B, 3 to 4 G. C, 6 to 8 G. D, 10-12 guy.
That's standard value without medical support. That's B, 3 to 4 gray.
Right again. Question 3. Which blood cell type drops earliest and most dramatically after TBI? A, erythrocytes. B, neutrophils. C, platelets. D, lymphocytes.
That's the lymphocytes. Super radiosensitive, so D, lymphocyte.
You got it. Last one, question 4. Exposure to over 50 gray. Rapid onset confusion, ataxia, seizures, coma, death within 48 hours. What syndrome? A, hematopoietic. B, gastrointestinal. C, cerebrovascular, CNS. D, pulmonary.
Super high dose, rapid neurocollapse, fast death, that's classic C, cerebrovascular or CNS syndrome.
Excellent. Okay, just to quickly wrap things up, we've covered the big 3 acute radiation syndromes, hematopoietic, GI, and cerebrovascular.
Yeah, we hit the dose ranges, key symptoms, those timelines, prodromal, latent, manifest illness, the target organs, and why people die from each one.
And stress the importance of LD50-60 as that key benchmark.
For everyone listening, especially residents prepping for boards, understanding TBI syndromes isn't just about lists. It's about seeing the connections, dose, tissue sensitivity, the cascade of organ failure.
Exactly. Remember that mnemonic, higher the gray, closer to heaven, and those pearls. Early vomiting, lymphocyte drops. Those are your practical clues.
Think about how the different sensitivities of stem cells versus mature cells drive the whole sequence of events. It all links back to basic radiobiology.
You can find practice oral boards over at radonsmartlearn.com and definitely subscribe to Rad on Smart Review for our next deep dive. Thanks for tuning in with us today.